Can everybody hear us okay? I saw some mentions of echo, but if audio continues to be an issue, let us know. Thanks everybody for joining us today as part of our VISN 17 Center of Excellence Ethics and Diversity webinar series. My name is Laura Zambrano Vasquez, and I am delighted to introduce today's speaker, Dr. Samuel Lustgarten. Dr. Samuel Lustgarten is back with us by popular demand, given the success of his participation in our webinar series last year. He's a licensed psychologist, assistant clinical professor, and assistant director of the Counseling Psychology Training Clinic at the University of Wisconsin-Madison. Over the last 6 years, he has been providing privacy and confidentiality consultations for university counseling centers, academic institutions, APA divisions, and private practices. Dr. Lustgarten has concentrated on various technologies providers already use, such as telemental health therapy, digital assessments, electronic medical records, email, and text messaging. His research focuses on psychologists' ethical considerations and decision-making processes at the intersection of technology and psychology. His scholarly work has been published in American Psychologist, Clinical Psychology, Science and Practice, and Professional Psychology Research and Practice. We are very excited to have him join us once again today. As we all know, this is a very timely topic as we all continue to use telehealth services more and more. So please join me in welcoming Dr. Lustgarten.
Thank you so much, Laura, and thank you, Lauren, too, for hosting this session. I am thrilled to be here with you all again. At the outset, though, I do want to make sure that you can all hear me okay. So I am taking a peek at the chat box. If you can let me know, just want to make sure. It looks like a lot of yeses. Terrific, perfect. Well, as Laura was saying, I am Dr. Samuel Lustgarten. Feel free to call me Sam throughout this. I am licensed both in the states of Oregon and Wisconsin, also a host of the Clinical Consult podcast from the National Register of Health Service Psychology. You can feel free to reach out to me through any of these means in the future. If you have questions about the presentation today, my goal is to talk about some key areas today. My guess is we may not have time to reach everything. And my hope is that this serves as a reference material for you to come back to. And like I said, if you do have questions in the future, please feel free to reach out to me by email, Twitter, my website, whatever you feel is most comfortable. Today, I want to talk about this concept of the office being everywhere and nowhere. And hopefully that's making some intuitive sense when I say that. But what I mean is that we have moved largely from those office spaces. And now we are using our technology, our computers, and having to deliver services from all over the country. So in many ways, our office is nowhere, that physical space, and it's everywhere because it follows us wherever our computers can go. And while we do that, it's important to think about some key areas. And today I'm going to be talking about things like interjurisdictional practice, the digital divide, and what that means for our ethics going forward. I also have a little bit of an outline for us here today that might help us stay on topic. So one, we're going to review what technology we're using, examine the practices we have and some of the common challenges we may be facing, and then talk a little bit about actions we can take to prepare and plan for the future. Again, the future is looking like we are going to be embracing telepsychology more than ever before. You know, as I talk to providers and even those of you in this group, I've heard about this shift that y'all are having to make. And sometimes it's a dance between, you know, are we in person? Are we at a distance? Are we doing some sort of blended kind of mix of meeting with some folks in person and some at a distance? And I think we're going to be having conversations like this for the foreseeable future. These are really, really important questions we're having. And I want to try and get at the idea of how we can prepare. I'm seeing in the chat box that audio is going in and out. So let me just go ahead and I'm going to do a little slight change here to see if it helps. I'm getting some mixed reports. I'm going to take out my headphones just in case.
All right, can you still hear me? Okay, great. Thank you so much. I really appreciate it. Hopefully that continues to be consistent for us. Just took out my headphones, so. Last time I talked with you all, I emphasized and I even talked to you about this idea that we've been using technology already for some time. I think some of us, even for me sometimes, I took it for granted that we were using this technology already. And I think it's important to note that, during my talk today, there will be some review from my previous presentation and then some addition. And my hope is that for those of you that didn't attend my talk last time, that you don't feel totally out of place. And that's my goal. And even those of you that did attend the talk in May of last year, hopefully this is a nice refresher before I build on to some new things. So some of the things that I know I took for granted early in my work as a psychologist were things like email. Oh my gosh, I'm emailing to coordinate scheduling. I'm emailing with the client if they suddenly have something that comes up and they need to reschedule with me. I'm also getting unsolicited emails sometimes from clients and having to manage our boundaries, So email for me is not a primary mechanism for therapy personally, even if it may be for others in different treatment modalities. The second one, electronic medical records, another area that for many, many years now, we've been either transitioning to or already using. And we may take it for granted that, oh my gosh, yes, this is a key part of how we use technology to provide services today. There's a difference, though, between like the ancillary provision of services and the primary provision of services. Ancillary, a good example of that would be things like EMRs or EHRs. Primary are things like text messaging or televideo, where you might actually use interventions or check in with people along the way using those kinds of modalities. Televideo, telemental health, there are some I think issues in the operationalization of terms, but generally speaking, when I say that, I mean things like video calls, what we're doing a lot of these days. And the last piece is around digital assessments. Digital assessments, they could include things like giving a WACE or a WISC, or even nowadays a PHQ-9 over the internet. The research that is brand new is pointing to a massive change in telepsychology use. Research that was done before the pandemic suggested about 7 to about 29% of psychologists and other health care providers, mental health care providers that is, were using telepsychology prior to the pandemic. Afterwards, about 83 to 85% of you all are saying you're using some form of telepsychology today. This is a massive revolution that we are a part of. And again, this is something that I talked a little bit about in May, but we are seeing the effects even more so today. And because of that, like I was mentioning earlier, I think it's really, really important that we examine some key areas: interjurisdictional practice, this concept of the digital divide, and the last piece is around ethics. So when I talk about interjurisdictional practice, my gosh, that multisyllabic word, it's going to get me at some point. But when I talk about that area of practice, I'm talking about how our federal laws and respective state laws might apply to our provision of services with a client or patient. What happens now when your office is a laptop when it comes to regulations and our legal considerations? We're really good at this. We're really good at those in-person conversations. We've spent years of training doing the in-person, couch-to-couch or chair-to-chair conversations. We know these. But now we're having to, more than ever before, adapt our care for distances that are well beyond the office. And sometimes there are situations where our clients surprise us and they're even further away than what we originally thought that they would be. Maybe they're on vacation. They've taken some sort of trip and driven to a different city or a different state, possibly even went to a different country. And in those circumstances, what do we do? How are we morphing and adapting our care for the needs of today? One of the things when we're thinking about interjurisdictional practice is our law that we're looking at. What laws do we look at? What regulations do we pull from to inform our practice in these moments? There are questions that come to mind that might help inform that. So I think to myself, where is my client? Where is my client physically? Where am I physically? And then where are we? The where are we question nowadays is around the concept of the digital space. I'm going to take a pause just in case we've lost audio again. Now, and I hear like a mix here. I'll just take a pause just in case it might come back. Okay. Thanks so much for communicating those along the way. I really, really appreciate that. All right, so the last piece, that last question. So where is the client? Where am I? Where are we? That's a digital question. That might be we are on this Adobe Connect software to meet with somebody. That Adobe Connect software might be where we are in a digital space, a shared space for our meetings. But when it comes to jurisdiction, especially if someone is outside of our jurisdiction, we need to be thinking, where is the client? Where is the client is often where we're going to find the answer to the laws and regulations that we need to be following. Just as a little update, no VPN on my end, but if I did have one, I would definitely close out. That's a good question. I appreciate you asking that. I always look and I always love to share this quote that comes from a law review, a law journal article from Siri in 2017. The author writes, there are two notable suggestions for resolving the choice of law issue concerning, and I'm replacing the word telepsychiatry with telepsychology. One suggestion involves the idea that the patient is, quote, electronically transported, quote, to the jurisdiction where the provider is located, right? So that would be, where am I? The other is that the provider might be deemed to have personally availed themselves of the patient's jurisdiction. So even though I may be in the state of Oregon today providing services to someone in the state of Florida, in this second one, I need to look at the state of Florida to help guide my jurisdictional practice and thinking around laws. During COVID-19 and in this unique period that we're working through, there have been many states signing emergency orders regarding telehealth across state lines. And this has allowed many providers to suddenly adapt their practice and become more flexible. And I always like to say, so in this example that I brought up earlier around, being in the state of Oregon, licensed in the state of Oregon, but then serving or having to potentially work with a client, let's say in the state of Florida, for example, I need to do my due diligence at this point to seek out some answers. The ASPPB, Association of State and Provincial Psychology Boards, has created an incredible table, and I've included a link at the bottom right of this slide. Hopefully you can reference at a later date. But the table puts together each board of psychology, each state's board of psychology, along with information about what they've done during this unique period of time to help assist providers providing care to their patients or people that are within their state on a temporary basis. In the example of Florida, just to take it a little bit further, so I would look at this table to help me understand what these rules are from an interjurisdictional perspective. And then it might be worth taking a little bit of a peek at the specific language of the emergency order. So in the case of Florida, that's Governor Ron DeSantis, or it was right there, writing, I can't remember the exact date when it was written, I think early in the pandemic though. And at the bottom part of the screenshot that I have there, it says not to exceed 30 days. Okay, and so what the state of Florida and the Florida Health Department is saying is that they are okay with providers providing care across those state borders, across jurisdictions, if the patient or client is in those borders for no more than 30 days. So it really needs to be a temporary kind of basis. Other states have stated different kinds of dates or periods of time, but it's really, really important to know that you can come back to that table ASPPB put together, and there are other organizations doing it, that are putting together whole country lists of jurisdiction. And that's not even to mention jurisdictional questions that might come about outside of the country of the United States. You know, what if my patient has temporarily gone to Canada? Or what if I'm working with a student and that student has returned to the country of China? What am I doing? If I'm going to be providing services to that person, what am I doing to better understand the jurisdictional questions that might be at play? And I need to be looking usually at where the client is. I'm not going to belabor this point, but I do want to say that there are incredible developments in the field. The Psychology Interjurisdictional Compact, PsyPact for short, has been working to help providers work across state borders more than ever before. You know, because we have differences in our laws and jurisdiction between federal and state levels, we constantly bump into this issue where you're licensed in one state, but unable to, at least legally speaking, provide services across state borders. And PsyPact is working to advance this on a national level. The darker blue states, if you can see those colors, states like Colorado and Texas, those darker blue states have all signed and enacted the legislation to help activate PsyPact in their state and allow providers to transport themselves, if you will, to where a client might be on a usually a temporary basis. But this legislation is really, really powerful and advancing in other areas too. So we have the lighter blue states which have signed legislation at their state legislative level, but it's not activated yet. Meaning that oftentimes states will sign a piece of legislation and it will be activated at a set date in the future. Our darker kind of black color states like Washington and the Northwest there, those are states that have legislation in their states, but they're not signed. So maybe people are talking about it, there's a bill that needs to be passed still. And then, as you might imagine, those gray states out there, those are states that have not brought a bill to the table, they have not signed any legislation, and again are not members of PsyPact. At the end of each of these key areas, the interjurisdictional practice, the digital divide, and the ethics, I'm going to try to provide some key areas that we need to be thinking about, some recommendations. One, we need to be reviewing local, and I'm putting this in quotes, foreign laws, because I think we often think about foreign as in other countries, which it could be, but I also want to be inclusive of the idea that foreign might even just be a different state, laws of a different state. And we need to be reviewing and being mindful of how changes are being made even during this time of COVID. Frankly, I would say that this is more accessible and easier than ever before to provide interjurisdictional practice. But we will see what happens. You know, a lot of these emergency orders are for a very, very temporary basis, the orders themselves, and the actual care. Like in the Florida example, that's an order that's saying, hey, you've got 30 days to work with this person over the border. So let's say that I'm working with a patient, that patient flies down to Florida to take care of a loved one that's sick. I have 30 days. And then we'll see what happens, because these emergency orders are by nature a temporary basis. The second, we need to locate and confirm jurisdiction. I can't take it for granted that my patient, my client, is in the same place where we originally negotiated care. I am constantly asking my folks, even if I know they haven't been moving around, hey, where are you today? Or, hey, I noticed the background has changed today. I'm always asking that right at the outset, and I've been surprised at how many times when I ask that, someone says, "Oh, you know what? I've hopped down to California and wanted to visit somebody," and that right there, now I'm in this moment of now needing to adapt and think, okay, what are my relevant laws? I'm licensed in Oregon, but that person is now in California. The best thing for me to do is take a slow down and take a look at that table and see, what do I need to be keeping in mind if I'm even going to have this session in an interjurisdictional way. The next piece, keep in mind that sharing of resources is a vital part and more difficult, or can be more difficult, at a distance. I'm always mentioning things like the National Suicide Prevention Lifeline, that 800-273-TALK. Wonderful that it has the Veterans Crisis Line built into it as well. The second piece is around local emergency or 911 services and their availability. But in these first two, let me give you an example about this. With the National Suicide Prevention Lifeline, this works in the States. But if that person goes to, like in my example earlier, to China, we need to be mindful that giving the 800-273-TALK number, it may not be very helpful. Along with, there are parts of the world where 911 is not the number that people need to call. And so being mindful of how that number and what local emergency services exist or what they might be like would be essential. Even in more rural parts of the United States, we've got some questions about service availability. And so if I'm working with a client who's in the North Woods of Wisconsin and I'm in Madison, I need to be really, really mindful about what they're going to have access to. So maybe the Marshfield clinics are an hour or two away. Well, what does that mean if I need to get somebody help immediately? The third piece is around the nearest hospital link. I always send this to people, and hopefully when you see the slides, you'll be able to play around with this. I always send this link. It's a Google link to folks I'm working with. And let me show you, when you click that link, I'm in Portland right now, okay? But when you click that link, here's what happens if you're in Portland, where I am. It shows you all of the local hospitals and the VA, the Portland VA Medical Center. So this is a wonderful resource to think about, how do we use technology to actually facilitate best practices and better care? So using a link like that can actually customize it to the person you're working with. Regardless of where they are, if they click that link, boom, now they see local hospitals and clinics. I've got some questions about the link and if I can share it. I'll try to share it after I present. I'll copy and paste it into the chat. Thanks for asking about it. All right. I want to talk a little briefer, but still I want to talk a little bit about the digital divide. I think if you've heard of it, you may have heard it within the context of education. And let me tell you a little bit about what I mean by that. The digital divide is this idea that the access to resources, both digital and physical, like hardware, may not be equal for everyone. There are a few forms of a digital divide. Sometimes it's about internet and broadband access in more rural areas, but another key area or identity that we need to be paying attention to is income and social class and how that might impact access to care. Okay, and thank you so much, Laura. I really, really appreciate you sharing that link. That link right there, you should be able to, if you click on it, see your own local hospitals and clinics. Now, with the digital divide in our context, it's important to consider that hardware and software and broadband access may impact the care that you're able to provide. My gosh, every single day that I'm doing therapy with folks, I'm running into these issues. So it's important to think about them. There are a number of statistics that the Pew Research Center is putting out. In terms of broadband access, look at that rural number, which is the bottom darker line, at 63% compared to suburban access, which is at 79%. Smartphone access, again, 71% in rural areas. It's huge growth. You know, mind you, this is amazing growth from what they're saying is 2011, Oh my gosh, 21% of those in rural locations had a smartphone in 2011. And now look at that, in 2019, 71%. And so we got to imagine that that's even higher today, but it's still unequal. Tablets, there's a little bit of kind of variation there, and it's arguable how necessary that would be for some rural Americans. So there's a little bit of a mix there, but I would say that desktop and laptop access and the differences there are very important as well. So this is going to impact, right, the care that you can provide. We might assume, hey, you know what, all you need is a webcam and a good internet connection. I'm in a city, and you know, how hard could it be for that rural American to connect with me? Just hop onto Zoom. But what we've noticed, and what you've probably noticed over time, is that can lead to delays and bandwidth lags. I'm going to talk a little bit about a recommendation in a little bit that might help with that kind of stuff. I talked about how it can also be unequal across identities. So lower income Americans, generally speaking, have less access to technology as well. So those making less than $30,000 a year, that darker blue color, look at how different that is. 18% to 64% in the 100,000 plus bracket for all of the above differences in technology adoption. Huge, massive differences. So when I am thinking about, oh my gosh, how great technology is, it's going to provide accessibility, I really, really need to be thinking about how identities are going to impact these. And I saw a brief little comment out of the corner of my eye there as I was talking that it doesn't even take into account racial and ethnic gaps and so many others that might also be impacting access to technology. You're absolutely right. I have this little screenshot of a Milwaukee Journal Sentinel article that just speaks to this idea. You know, I brought up that idea of if I'm in the, Madison or a city center in Wisconsin, and I am providing services to someone in the Northwoods or in a more rural area of Wisconsin, the digital divide is really deep, really, really deep. Not to get too deep in the woods, if you will, but no pun intended. The broadband access is not. There's no profit incentive. That's all. That's to keep it simple. There's no profit incentive for internet companies or telecom companies usually to develop in really, really rural parts of the country. And as a result, that infrastructure is well behind city and urban centers traditionally. So here are some recommendations given the digital divide. One, I never take it for granted. I'm not trying to say that I talk down to people, but I never take it for granted that my understanding of how technology works is how the person who's receiving it is thinking too. I never take that for granted. So it's always good to give some basic guidance to an individual as you're starting. Hey, just so you know, at the bottom, you'll notice there's a speaker button. If you press that, or the microphone button, if you press that, that'll mute yourself. If you unpress it, that'll unmute and I'll be able to hear you. If you're having problems with technology, you might do this or that. So offering instruction, giving people a little bit of guidance about this new modality seems really, really important. And it's not instruction we ever had to do before. This is not language we had to incorporate when we were in person, right? When we were in person, we don't have to explain that we might have technical issues or how do we deal with this or how do we log in. As long as you show up on time and we walk back together, we can get started. Number two, provide options and be prepared with backup. If you are thinking, okay, we'll default to a video call, what kinds of backups do you have ready? Do you have a phone that you can reach them by? A professional one, or could you turn the video off for a temporary basis? Many meeting services allow a call-in backup option too, where you could be in a digital kind of teleconferencing video call software and have the person call in. Options are important, and we've got to get flexible. The third piece is around utilizing services that I say, quote, surf bandwidth variability. And I want to try and break this down as much as possible and make this more accessible to us all. What I mean is that when we're usually browsing the internet, whether we're in rural locations or more urban locations, whether there's the digital divide or not, when we're browsing around the internet, checking out our news, going to Facebook, going on Twitter, etc., those services are all providing data behind the scenes and then showing it to our face on whatever screen we're looking at or whatever device we're reading with. There might be delays, there might be latency in that process, but eventually it gets loaded up. Another example, if you're on YouTube or watching Netflix videos, you might see a constant stream, like the video is crisp and clear. It doesn't break up, even if your internet's kind of slow. And the reason that that's happening is because it is moderating, surfing, how much bandwidth you have and buffering, okay? It's moderating the bandwidth and buffering the video. Buffering means it's loading it behind the scenes so that it can show you it as a crystal clear image as best as it can. However, when we're doing video calls or even things like this, we can't buffer. And the reason is because it's live. The video players can't predict what's going to happen next. And if they did, that would be pretty amazing. And so we need to think about services that adapt to high bandwidth zones and low bandwidth zones really, really well. And so I'm not going to talk about specifics during this talk. I'm not trying to market particular materials, but if you do have questions about video conferencing software, televideo software that does this better than others, I'm always happy to talk about those with you all. All right, this key third area that I want to talk about is around ethical considerations. How do we apply our ethics to this complex field-based challenge? I'm going to kind of go one by one on this slide. So if it's blank, that's as it should be. And if you all attended my first session in May, you probably saw this before, but this is an example where I'm trying to just make sure we're all on the same page as much as possible. So when we're doing anything in the digital space using technology for the provision of psychology services, we kind of have this rough example, right? It's you and it's a client, patient, and they both have their respective devices. Could be a phone, could be a tablet, could be a computer, could be a webcam and a professional device. And we like to kind of think, you know, oh, and it looks like my animation's a little delayed there, but we like to kind of think, hey, you know, when I send a text message to a client, I press the send button and it gets sent. That's it, nothing more. And it shows up at the client's device. But we also need to consider that there are a bunch of intermediaries and other kind of telecommunications things happening behind the scenes. And we don't have time to go into all of them, but there are vulnerabilities as a result. So there are groups of folks, and I'll just say, you know, governments, organizations, collectives, and individual hackers who, from the line down, so that's the vertical line, down from the kind of red person, down to that line that's going horizontal, there are governments, organizations, collectives, and individual hackers who are very interested in breaking the links between devices, getting in between those communications. Alternatively, those same folks, those same entities have an interest in getting in some people's devices. So an example of that, and I apologize if you hear any background noise, there's some people working in my hallway, but the example of that would be that those governments, organizations, collectives, individual hackers could go ahead and send a text message to me. In that message, it says, you have an appointment for 12 p.m. Please click to confirm. And if I'm not sure or curious or confused why I got it and I click it, that may now all of a sudden allow a group or an entity to gain access to my device. And the same could be true for clients or our patients. I always like to think about and consider the role of the physical other. So any coworkers, partners, friends, roommates, random people on the left side of the slide, or partners, relatives, friends, roommates, random people on the right side of the slide. It's important to consider that we're talking, technology. Well, the simplest way to gain access to a device is to be close to it. So if I have my partner have access to my phone, what will she see if she opens up the phone app? Will she see that I have protected health information there, whether it be a phone number or a specific client's name? Will she see emails if she opens up my Gmail account from clients or to clients? And that's just a benign example. Never mind someone that is purposely trying to gain access to something. On the other side, I always like to talk about how it's important to consider situations where clients might be vulnerable or at risk of things like domestic violence, intimate partner abuse, things like that. In those kinds of situations, what I'm sending and what we are communicating back and forth becomes essential to think about. Oh my gosh, is it vital for their welfare? We talk about our ethics and some of our considerations, and this is having us get creative and think beyond the office, beyond the four walls, more than ever before. And the last piece that I always like to talk about is we could potentially have a third party act like a client. So if I have a client that their email is john.smith@gmail.com, and john.smith1@gmail.com emails me, what am I going to do? Or john.sm lowercase lth@gmail.com emails me, what am I going to do? And I say a lowercase l because that can often look like an I. And in those kinds of situations, and I'll tell you just from my own practice, I always look at the email address, and if I know it for certain, I will respond. And if I am just not sure, because I'm dealing with a lot of email addresses these days, I always go back to that patient's chart, look at their email address on file before I ever respond. All right, some important ethical standards. It's not all inclusive. It's not every single standard that we could think about. When I go through the ethics code and I compare one-to-one what I'm talking about, there are many things that I could be talking about with you today. I just want to give you a handful. One is around resolving ethical issues. This standard, it says resolving conflicts between ethics and law, regulations, or other governing authorities. I didn't used to talk about this standard, and I don't even know if I talked about this standard in May with you all. But frankly, as I thought about what can I provide as a little sequel today, I thought interjurisdictional practice would be really important. And then it suddenly dawned on me, my gosh, oftentimes I thought about this standard as being, my boss or my clinical director tells me to do something that I think is just like ethically wrong. How do I resolve that ethical issue? But now I want to sort of present that this standard may be helpful in thinking about jurisdictions and that practice. What if I have a conflict between the law of a different country or a different state and what I believe is ethically right? I don't have the answers here. And if I did have the answers, I think you should really call me out for it. I always believe that ethics is more complicated than a simple yes or no. And I think I'm seeing some great comments in the chat box here too, that there are unique policies within the organizations and places that you work too, that might define some of these for you. The next one is around competence. I never assume that in using a new modality, whatever it is, that I'm going to walk into a professional setting and session and be a competent provider. I've always got to be thinking, hey, if I read one paper about DBT, that does not make me a competent provider. If I read one paper about, multicultural competence, that does not make me multiculturally competent. I need to do more work than that. And so the second standard here around competence is around the idea that when we use technology, we need to be thinking about our education. So today, hey, maybe you get to check this one off. You did the trying to maintain competence around technology here with me today, and I'm thrilled to have you along. But that doesn't mean that we get to check it off and it's done. Technology is going to change, and it adapts rapidly, more than we can ever expect or know in the future. And so we need to keep working at that. The third one is around human relations. The specific standard that I want to talk about is informed consent. With informed consent, we often think about, okay, I need to be disclosing, advantages and disadvantages of the care that you might receive, some of the limitations to confidentiality, things like that. That's all wrapped up in the informed consent process. However, one of the areas that we have spent less time thinking about is how we might inform our clients about the technology we're using. An example of this might include, when we email back and forth, that is intended for scheduling only, and you will only receive responses from me between the hours of 8 and 5, Monday through Friday. That would be an informed consent about the technology we're using in the domain of email specifically. The next one, around privacy and confidentiality. Sorry about that. The next one is around privacy and confidentiality. This is one that I'm not going to spend too much time on because we've been really emphasizing this point in the last few slides, but that's around maintaining confidentiality specifically. We have an utmost legal and ethical obligation to protect the privacy and confidentiality of the protected health information and contact that we're making with our clients. So we just need to be thinking, hey, technology can stress some of that, some of our ability to do that. The next one is around record keeping and fees. This is a new area for me as well, and I actually have a journal article of mine that's from 2020. The short title is Data After Death. And if you're looking for the specific title and everything, or if you'd like me to share that with you personally, happy to do that. Just feel free to reach out to me by email. But I think that this is going to be increasingly important area for us to consider. Basically, everything we do on the internet, everything we do with technology, it tends to leave breadcrumbs. Breadcrumbs being like little bits of data behind everywhere we go, little bits of data. I send an email, there's little bits of data. The companies that help send that email, the email itself, little bits of data. And those are getting sent all over the place all the time nowadays. When we are communicating with our clients, storing information in electronic medical records, sending emails, text messaging, little bits of data. And so for me, in my work, I'm thinking, what am I doing to manage that data? Maybe after I leave a company, maybe in an untimely death, or maybe just because it's a standard of care. There aren't any specific ethical standards that say you need to delete data in this period of time, but there are some guidelines that say around 7 years is a common period of time where you might think about deleting data. So I'm always thinking, well, how do we know we're actually deleting that data? Who's deleting that data? Where does the data go? Because you know what? Contrary to just emptying the trash bin, data can be a little bit tricky to delete. And I'm always happy to talk more with people and, of course, share that article with you if you're interested in learning more. The next piece that I always like to say, too, is that the APA Ethics Code is helpful for informing our standards, but not all-inclusive. I always pull from the American Counseling Association's 2014, and I really want to emphasize this, 2014 Ethics Code, that revision of it, that addition, that already in 2014, 7 years ago, was included Section H, Distance Counseling, Technology, and Social Media. I have a firm belief that the ACA was doing a fantastic job predicting what we would be seeing next. And I've been surprised that the APA Ethics Code hasn't explicitly brought in a section or incorporated more language around technology. So if you're looking for more ethical guidance, I think the ACAs might be very helpful. All right, some future challenges and opportunities that I think we're all going to be up against and have opportunities to do. The first one is group telehealth. I know a lot of providers that are doing individual care right now, the vast majority. The data is a little bit unclear about how many have switched over to group, but I know many folks that are. And to me, I think the challenge here is that it multiplies problems. So one person's problems with technology gets multiplied by the number of people in a group. If I have 6 members in a group, that means that I have 6 times the challenges possibly. So if I've got one person smoking during the session, I've got another person who can't figure out their video. I have one person that insists on turning off their video. I have one person who keeps getting interrupted by their child during the appointment. All of a sudden, we're losing time. Whereas in an in-person group, we would be able to fly through certain areas. Now we're having to slow down. So that's a real challenge. However, I do want to really acknowledge, I don't necessarily see myself as a technology pessimist. I'm a pretty realist or optimist at times around technology. And so I do think that group telehealth is actually going to be an incredible opportunity for access and potentially affordability for a number of populations to get help. The second is supervision of a supervisee. Oh my gosh, we've got a lot of questions about what is going to happen when a supervisee is in a different state than the supervisor, or a different state than the client, patient that they're serving. As of yet, I think we often need to go back to where is the client, that question that I was talking about earlier, and where is your license as the licensed professional. So if you go back to those tend to be the fundamentals, but I can envision a future where we're considering that question a lot more seriously. If you've got a supervisee in a different state than the client and you, where you're licensed, that potentially poses some additional risk. And so I think we got to ask ourselves, both as a field and within the legal field, what we're doing to protect those we serve and also help facilitate care. Because we've got an opportunity here too, where supervisees could be in a home location or home state, allowed to access training more easily than having to attend something at a specific city or time. The third one is around billing and insurance. I think we've got a lot of open-ended questions still about how insurance is going to approach some of the challenges when our clients are moving about. What happens then? Right now, a lot of insurance companies are providing kind of like emergency orders, if you will, to allow for telehealth reimbursement. But what happens when that changes? What happens when we're not in a pandemic, but we've been kind of getting used to this world of distance-based care? And we may have a little bit of a dance ahead as a result of that. I don't have answers for this, of course, because I'm not in insurance or billing, but I think it's an important question that we all need to be thinking about and trying to advocate. All right, I have some broad-based recommendations that are informed by some of those ethical standards and questions. One is it's important that we find ways to adapt informed consent. We cannot control every security vulnerability, and I guarantee that none of us on this call, me included especially, we can't know. We can do our research, we can read privacy policies, we can look at terms and conditions, but we can't know all of the security vulnerabilities that might be in place. It's important that we acknowledge humbly that there are some risks to using technology, and here's how we're mitigating those risks. Number 2, sign business associate agreements. That's what BAAs are, business associate agreements, and reduce protected health information. Meaning, with companies that you're contracting with to provide a service, could be cloud storage or video conferencing software, make sure that you are either signing a business associate agreement or there's one that's built in as a part of your contract for using the service. And when possible, reduce the amount of protected health information you put into third-party providers and encourage patients to do the same when they can. So for instance, if I have a patient who is joining a video call on a service that is not created by me, I might say to them, hey, John Smith, instead of saying John Smith, you can just put your first initial, or you can just put like the date of your service. And That way, at least their name is managed. It's a little example of it. There are also some examples that come into play with digital assessments too. You know, what names do you use, things like that. The third is around developing competence. We talked about that earlier, so I'm not going to go into too much detail there. 4, consult with experts, like you're doing today, like you'll do in the future, I trust. Talk to people that you know. Talk to people who seem like they've got a handle on this. Hopefully you've got some folks in your organization too, I hope so, who you know and trust, hey, they seem to get this or have got this down. And I don't just mean IT professionals. I mean practitioners who can also help you in this process. Because going it alone, there's some vulnerability there, both for you and your clients. 5, use encryption whenever possible. Encrypt your phones, encrypt your text messages, encrypt your emails, etc. There are some specifics that I'd be happy to talk with people about beyond probably this brief recommendation. 6, think about appointing a privacy officer. If you are in a small group practice, think about someone who might be able to lead the charge at your organization. And some organizations are legally mandated to have it as well. And so just be thinking about who might you turn to support you in this endeavor? Who might be able to, take it upon themselves to research and spend time getting to know these technologies? And if you're interested in more information beyond this presentation, I always point people to the Telebehavioral Health Institute. I've got no affiliation with them, but I find that their resources to be helpful. They've got a whole bibliography page of pretty recent journal articles that are pretty helpful as well. And right at the bottom of that, it says presentation from the Institute. I believe this is publicly accessible. It's like a Google Slides. And if you're interested in that, that can be helpful. And hopefully the link, it will be accessible in your own slides. The top presentation or publication, Data After Death, Record Keeping Considerations for Unexpected Departures of Mental Health Providers. That's when I was talking about record keeping and fees, a new publication. Happy to share that with you all if you're interested. And finally, I want to leave a little bit of time for questions, answers, that kind of stuff. I just want to read this one quote because it's been my inspiration over the last 6 years since I read it. The ability to search the web, develop ideas, and communicate securely may be the only way in which many can explore basic aspects of identity, such as one's gender, religion, ethnicity, national origin, or sexuality. Thank you all for being here today. It has been a blast and an honor to come back. I am so thrilled to be talking with you all and that so many of you have been interested in learning more about how to care for our people and incorporate technology safely into the world.
On the chat, some questions, comments that came up. Honestly, it even sounds like having this conversation is helpful because a lot of people have some additional answers, particularly in the VA where we have specific rules, regulations, and I think, at least to me, it was really reassuring to see where the systems that we have in place may help address some of those ethical concerns that exist when providing telehealth. But some of the questions that came up, and feel free if I missed it as I'm asking Dr. Lustgarten, feel free to drop them in the chat box here. But some of the questions that exist that came up, for instance, for a lot of VA providers was if some of these considerations that you were talking about, providing care across lines, would apply similarly if there's what's considered federal supremacy. I think the consensus was that it does not apply in the same way for VA practitioners, but there was questions about how, even though maybe we're more able to provide services as long as veterans within the U.S., of how duty to report can change across state lines, right? So if, like you said, you're in Oregon providing services in Florida, and something comes up in terms of like an abuse or something that you would report, is that something that you would gauge based on your laws as a practitioner, where the client is at? More information about that was something that came up.
Yeah, that's a really great question, Laura, and I appreciate you highlighting it. I am not going to say that I'm an expert in that specific domain, because it does step out of the like technology specific, but it is a great question about interjurisdictional mandated reporting laws. In general, I think about taking a conservative approach in those areas. And so for me, my first step is, where is my client? And if my client, even temporarily, when they report something, is in a different state than me, I'm going to look at that state within which the abuse is happening and my client is at, to see what the mandated reporting laws are there. If there are ever any questions, I'm always like the first one. I'm going to call up CPS or, just to consult. Because even if I'm wrong, even if it's not something that needs to be mandated reported, this is a moment where I get to say, hey, just have a question, want to consult. Not sure whether this falls into your jurisdiction or mine. And so going, cautiously and judiciously through that process, taking time to consult, but oftentimes leaning towards where the abuse is actually occurring. That home state of where that might be happening is often what might help guide next steps.
I think that makes a lot of sense, and I think you bring up a good point of like an abundance of cautiousness as we're approaching these tough situations where there might not necessarily be an absolute answer that can provide that. Another question that came up was Mr. Gibson here, Mr. or Miss Dr. L. Gibson said, in addition to some of the comments above surrounding practices across state lines, it's important to consider the best fit for holistic care and whether a veteran is being attached to their local clinic for services. He or she brings up a comment of temporarily traveling is one thing, or living near a state border, but the question that came up is what happens when some of these veterans are moving across the country in terms of relationship continuity of care. And I don't know if there's a specific question, but people are asking, what do we do with people that are more like snowbirds, right? People who are used to having 2 different homes or VAs for several months a year, and if there's specific considerations we should take into account.
Oh my gosh. This question is honestly like making me smile and cringe at the same time, because I think we're going to be needing to ask ourselves these questions more than ever before. I don't know of any research off the top of my head about continuity of care and increasingly this ability to practice across state lines and be flexible when people take new homes temporarily or travel for some period of time. I think it is a fantastic question where we need more research as rapidly as possible. They might give us some clues about how that might affect relationships. But I'll tell you, having seen people in Wisconsin and Oregon, sometimes at great distances, continuity of care has been possible. And in some ways, I do think we have some fantastic questions to ask ourselves about what that means about relationship building and transitioning care. Where I might have ordinarily, or where someone might have ordinarily terminated and concluded care with a great number of people, it is accessible and possible today. And so we've got some important questions to ask about the conclusion of care when people move, whether that's you, the provider, or the client. I think it's a fantastic question y'all are asking and bringing to the table, and one in which I feel like we need some answers. The sooner the better. Great question.
Well, we're approaching the end of our time here, and I want to be mindful of people's time and scheduling things around this time. I really appreciate you coming to share this information with us today. I will remind everybody, like you said earlier, that you are open to receiving questions from people if other things come up. And also do a quick reminder that our next presentation as part of our Ethics and Webinar series is going to be on May 12th, Wednesday, May 12th. So you can see the information pop out now. and it's going to be on adopting a multicultural orientation framework. So you see the TMS course number there. You can also download it from the files if you want more information. It has a link to subscribe so that you can receive notices about future trainings that we may have. But we thank everybody for joining us. We thank you, Dr. Lustgarten, so much for bringing us this information. I know there's going to be continuing questions coming up. So if we didn't get to your question, then please know you can reach out to Dr. Lustgarten, and he might still be a resource for you. The slides are available to download, and you might have access to all these different resources shared today.